like researching data collection approaches that we were currently doing, as well as opportunities that we had to improve those methods. And so that really looked like going out and being in the community. So our MAP partnership, which is our mobile clinic, going out with the Moving Ahead partnership, the restructuring of a committee to understand how are we investing our time and our money in our community, and then also looking at our data differently and really charging our team members with being with training around cultural competency and respect and dignity, being treated or being posed to our patients at all times and at all circumstances, which has really always been a tenet of Stormont, but really calling that out and holding ourselves to a different standard at that point. The next section of our phase was really deploying those data-driven approaches. I won't touch too much onto that because I'll be going a little bit more in depth in that in the next couple of slides. But we had a health equity and policy position created, and really in that role, we were able to update our data and launch a campaign around that for patient education. And then the next ones, once we have our data, the question is, what do we do with that? And the digging deeper and building momentum was really honing in on the issues that we felt like we could be impactful with in our community and identifying what our community was telling us were priorities and matching those two things into data-driven initiatives. And for us, that looked like going really deep on maternal health and behavioral health. And so today and beyond, what that looks like is sharing the work that we're doing, just like in settings like this, because we don't want to be the only people that are having success in this area. We want it to be evident throughout the data and across our state and our nation, because these outcomes are a positive thing for our communities, and it's what our communities are telling us are priorities for them. Additionally, we've gone deeper into our initiatives by expanding the roles that are working, like adding in community health workers, which we call community health advocates, adding social work within our OBGYN services, and making sure that we're really hearing and building capacity around listening to our community needs by buffing up our community health needs assessment process in that cycle. So we can go to the next slide. And so the question happens that we need to ask is, how do we know what a community needs? And so we can go to that next slide. And for us at Stormont, that really looks like being a leader in our community health needs assessment space. And for those who aren't familiar with community health needs assessment process, this is something that, at least for us, happens every 3 years. We're about to come up on our next cycle in the spring of 2027. And it is a process of surveying our community to understand and document the health needs and social challenges that people share. It's meant to be pretty wide in terms of the breadth of topics that we touch on. But in some topics that we know are documented issues that pop up again and again and again, there are opportunities to dig deeper to understand the why and the root causes of how these issues continue to perpetuate in our communities. It's something that's required by the IRS. However, different hospital systems decide, specifically nonprofit ones are the ones that are required, decide to invest maybe a little bit differently. Some use third parties, some do it themselves. We at Stormont really believe in being leaders in this space, and we also include other nonprofits in that process as well. Nonprofit hospitals aren't the only people that are required to do a CHNA. The health departments, FQHCs, and CCBHCs are also required. So we bring them along as partners in the CHNA process as well. And so on the next slide, you'll be able to see the partners that participated back in 2024. And you'll see that since we have a hospital in Shawnee County as well as Erie County, we conduct 2 CHNAs at the same time, which makes for a really fun spring. But it's a great process And it's great to get out in the community and really understand the needs that our community is sharing with us. So we have a great variety of different partners that lend a hand to making sure that we have a culturally and demographically representative sample of our community. The next slide, please. So the process of doing the CHNA is really built into 4 steps, at least for us. So that first part is creating the survey and disseminating the survey. We want to ensure that it gets to as many people as possible and as representative of a sample as possible. And one of the big wins from the 2024 survey, especially in Shawnee County, was that we weren't able to get to a culturally and demographically a culturally demographic that was synonymous with what our community actually looked like. So it was aligned across racial lines, which is huge and very difficult to do on a survey. And so that's something that we're really proud of. And so during the survey, we're also conducting roundtables, and we are looking to incorporate those teams that are those communities that are typically underrepresented that we want to hear from, because even if it's representative of what our community looks like, if what a majority of one group is responding, we want to make sure that we're hearing the thoughts and the opinions and the perceptions of those who might make up smaller numbers, but are just as important to hear from in our community. So those roundtables allow those voices to be heard and incorporated into the data analysis phase. The third part is, again, doing the analysis of the data to see which issues tend to rise to the top. And then the fourth step is conducting a town hall at the end of that with community members, nonprofit stakeholders, and community stakeholders to define what those problems were and to hear from other subject matter experts their take on those top 10 issues and narrow it down to a top 4 or 5. And in our next slide, well, these are the 4 topics that rose to the top of the last CHNA. So behavioral health, this is something that we see in almost every county in Kansas, but has continuously been a challenge for us. In Shawnee County, we also have neighborhood safety and housing, healthy eating, and health equity. No surprise, but the things that were identified within the CHNA for health equity were topics around maternal health and infant health. So things like infant and maternal mortality, teen birth, STIs were all things that we saw there were huge disparities happening across racial lines with those data points and needed to be called out as priorities for Shawnee. And then on the next slide, Geary County had some unique pieces to theirs. So a lot of their topics that rose to the top were around resourcing. So access to community resources, resources around youth character development, transportation, obesity, and then of course mental health. Again, behavioral health is something that we see across our region as being a challenge. And then the next slide. So now that we understand and we're able to identify what the needs of our community were, now it's time for us to dig deep. And so one thing that a project that I was able to lead and is still implemented here at Stormontville is improving the way that we collect demographic data. And the reason why this is so important is because you cannot accurately track how disparities are being improved or if they're not being improved if you do not have accurate data to see those changes happening over time. And so when I came to Stormont, I had the opportunity to evaluate the way that we were collecting data previously, and I found 5 large gaps in that. So number one, we had pretty ambiguous racial groups that we were asking. And on that right-hand side, you see the previous state of it. So we have some larger racial demographic groups that we collected. And then for ethnicity, we only asked if someone was Hispanic or non-Hispanic. We didn't get any deeper than that. And so that caused a lack of ethnicity data as well. Of the data that we did have that was good, we didn't know how to use it. So it kind of just sat in our EHR underutilized with tracking disparities over time. And there was a huge opportunity for us to dig deeper into that and to identify where there may be gaps. There were also some challenges within our Epic interface that we had to work through and get a little bit creative with our Epic builders, which was a lot of fun. And then lastly, there were some challenges with how we were able to validate our multiracial patients. So it's always been something that patients, or it has for a long time been, our patients have been able to select multiple racial groups. However, on the back end, when we're validating that, we had to ensure that we were using a special tool to make sure that those patients were counted accurately. And so when I was doing this work around 2021, 2022, there were some rules coming down the pipe, especially with CMS and Joint Commission, that may not be the case at the moment, but at that time, that was a driving motivation for a lot of our work there. And I'm glad that we were able to implement that and get it done, and be in line and actually leading in that cause. And we're able to guide some of our peers on that journey as well. And so for the next slide, you'll be able to see how we were able to update our MyChart and Epic interface to accommodate some of those changes and fix some of those challenges and issues that we had with demographic data collection in our new design. So you'll see we were able to add an ethnic background category. This was something that we did not have before that we added into our interface. And we also expanded the number of racial demographic groups and edited some of the language. So we did not have a Middle Eastern or North African racial demographic group before. That was added as a new piece. And we also updated the language for categories from just Hispanic to expanding that to Hispanic, Latino, or Spanish to update to what we were hearing and seeing in the literature about best practices for nomenclature for these racial groups. And if you go to the next slide, we were able to also create a list of tools to help clarify and bring clarity to what we mean when we say certain words. So when we say Asian, what does that mean? So we had a definition list of a sheet that we provided to our registrars that could also be provided to patients if they had questions or comments or concerns about what these mean. And then we expanded our list of ethnic backgrounds exponentially. So we wanted to go through and define by best practice what kinds of ethnicities we typically find in the United States. And so that was the basis of this list. And then we added, subtracted, edited based it on what we find in our region. So we kind of created the American Indian or Alaska Native or indigenous population, the ethnic backgrounds they were able to choose fully based on our population of tribal affiliations in our area. And then we know that we have different types of demographics that were incoming. So at the time, we had a lot of Ukrainian refugees that were stationed in Shawnee County in particular. And so that was something that we decided to add to our list that wasn't necessarily represented in the literature as at the time for a prominent demographic that would likely need to be represented. We knew our community and we knew that that demographic needed to be added in order to accurately capture the type of patients that we knew that we had coming into our doors. So we were able to be a little bit more creative with that. And I worked really closely with our IT team to build this from the ground up. And then next slide, please. So as you may imagine, the biggest challenge with this project from start to finish that I continued to hear over and over again was hesitancy from team members and hesitancy from patients, because the topic of race, ethnicity, ethnic background can be a very personal topic. It can be something that can turn inflammatory. And we realized that and really wanted to prepare our team in order to feel confident having these conversations and feel like they were supported with language that they knew they could lean on if they needed it, if they came into a particular situation. So we started with creating a response matrix for our team members. We gathered the typical responses that we heard from patients and created organizational supported language that our registrars or our nurses in the clinics could use to combat some of the curiosity or some of the hesitation that they may find from patients who are being asked these questions that they may not be used to. Because I think race is something that most people are maybe used to being asked, but ethnic background and that level of depth would be new for our population. And we wanted our team members to feel confident having those conversations. On the next slide, our next charge was making our patients feel comfortable and our community feel comfortable by knowing that these questions were coming and that they would have the power and be in the power seat with how they wanted to interact with this. We are very, very clear that these are not required questions. We are clear that we are not sharing this information outside of our organization, that the reason why we're collecting this information is to improve their care and to ensure that every single person that walks through our door is getting the utmost respect, the utmost best care, the utmost best patient outcomes possible. And so we launched a We Ask Because We Care campaign. I wish I could say I came up with that amazing slogan. I will say there were many other organizations who launched a We Ask Because We Care campaign prior, and we thought it had a great message and fit well within our branding. And so we took that on. It launched in May of 2023, and we got some slots on the news, and the news actually won an award from that segment because of how it was perceived in the community and their focus on talking about topics that people typically don't touch on from day to day. And then I worked with our marketing team to create a how to if people didn't feel comfortable talking about it in person at their appointment. There was also capabilities for them to update it anytime they want to from their device at home through MyChart. And we launched some videos of how patients can do that on their own, on their computer or their phone, and answer some frequently asked questions. Next slide, please. So once we were able to get the data collection piece down, now we felt like it was time to launch the programs that we could utilize that strong data that we were collecting and put it to use with tracking patient outcomes. So in comes a collaborative that we did with the March of Dimes called the Maternal Healthcare Collaborative. And this was a multi-year program that we did that was across multiple different departments. I guess the kind of stars of the show were our maternal health team. They really took this challenge and led it with so much tenacity, so much grit, so much enthusiasm because they wanted to see those positive outcomes. And so there were multiple pieces. The community accountability panel was a group that the March of Dimes put together through a different third party of community members that had no idea they were reviewing Stormont, and we had no idea who the community members were. But it was a good feedback loop of understanding how these initiatives that we were launching were being perceived in our community and opportunities that we continue to have to improve with how we present our projects. We also, from this collaborative, launched our Teen Birth strategy, and this is a program where birthing persons and moms are put at the front seat of their birthing experience. And this allows them to call a huddle at any time during their birth experience, and their care team, their clinical care team will come, their support people will come, and just have a group conversation about what that person needs in that moment to feel safe, cared for, and considered in their birthing experience, and has been a huge satisfier for our patient base from implementing this. And we're one of the few, I believe, in the nation who have implemented this and have really been leaders in this space with teen birth. Next, we did implicit bias training with our team members within our maternal health team. And this was something that was a great learning experience for all of us. We partnered with a third party community based group to review our policies within our maternal health space. So, our birthplace policies, there were some NICU ones as well. But anything that we felt like should have a community review process that could be subject to bias, could be subject to um, having considerations for different types of folks that might come through our healthcare space. We wanted those policies to be reviewed, and we got some really amazing, great feedback from professionals and community members that helped us to improve our policies. The collection of the maternal health data, all the We Ask Because We Care campaign information fed into this process and was very aligned with that project. And then we were able to learn from subject matter experts through educational calls with the March of Dimes. And they had wonderful speakers and wonderful subject matter experts come share their wisdom with us. That was super helpful. Ultimately, we have the goal of creating a culture of equity, a culture of excellence within our patient care, which has always been there, but understanding how we can look if there are any gaps, how we can fill that, and really get good feedback to see where we can get to even the next level within our patient care. And then, yeah, just putting the patient at the front seat of their care and making sure that they feel heard, considered, and cared for within their experience in our doors really transformed the way that we look at maternal health. Next slide, please. And so where we are now, a lot of all those initiatives that we saw, the collaborative has ended. However, we did continue the policy review until we literally ran out of policies to review. So that was a great a process. We're still doing teen birth. We still have the data collection changes in place, and we're just continuing to build on the progress that we started back in our journey in 2023. And so from that, we've just expanded the number of team members who are dedicated to this work. So we recently acquired the Lincoln Center, which is an OBGYN clinic, and they give those services. And we have integrated since a community health advocate, which is essentially a community health worker in that clinic, and also a social worker. And we are continuing to grow that team because we're seeing positive results from our from our patients, and great feedback from our team members that this is the work that's working for our community. And we're seeing that it's a huge patient satisfier as well to have someone walk through that process with them. And so there is cross collaboration with our care transformation team and our maternal health team across the OBGYN services, our birthplace NICU. There's a lot of collaboration, a lot of teamwork, a lot of just continuously touching base and asking ourselves how we can continue to be better and improve and meet our patients where they're at and fulfill the needs that we're able to fulfill. And where we're not able to fulfill, where can we partner with organizations who can to really close those gaps that we're seeing in care. And so next slide, that's really all that I have for you. I wanted to make sure I left my information. So you have my email and my phone number in case you ever needed to get a hold of me for any reason. I'm always happy to chat and collaborate and to just answer questions if that's helpful to you. And also love to hear what you are doing that's working for your communities as well, to see how we can continue to grow and evolve in this space, because it truly takes all of us to figure this out. And then the other slide that I have is just my citations um, from my slides. So I think I'm ready for questions if anybody has any.
Emerson, thank you so much. In the chat, any questions or please just jump in. Um, wow. Suddenly I want to do more. What a phenomenal progress of a thought. I'm just thinking about a couple years ago, Emerson, and your thoughts about how to start this process and the front line from registration to triage to phone call and how we ask the question appropriately and get data that's helpful. So kudos to you and your team. Questions or things that are happening at your sites regarding um, this complex process, but phenomenal work.
They're so quiet.
They're trying to figure out how to do this at their hospital. It happened
I
last
hope,
time she talked too.
yeah, I hope so. I hope so.
The also Emerson as a follow-up, many sites are starting to use Epic and similar systems, which is wonderful. But isn't it fascinating to see what is the autocorrect, I'll call it, for the patients? And I've told this story many times, but here at the Stormont Flint Hills campus, we kept finding everybody Hispanic. And I'm like, whoa, 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 which was being used on the birth certificate because folks were just filling out the Epic information to the birth. So, whoa, right? And there's automated systems that are great. And then that became a real big red flag to us when we realized that 100% of our patients were Hispanic because of the auto feature. Anyway, I'm sure there are stories from other places like that, but that's one of the moments where you have to stop and look at the data and realize something's wrong, right? Or we need to reconnect. Yeah. Have you had any similar stories of the autocorrect? I'm calling it the autocorrect or auto feature.
You know, during the journey of reviewing and looking at our original data collection, we found many quirks. That's what I'll call them. Quirks within our data that, and I think a piece of it is because race and ethnicity are just so personal and sensitive that, if something appears to be a way you don't want to second guess it or question it just because the follow up to that with a patient conversation can get touchy. However, the most important conversation that I had with our registration team, with our nurses, with our education team that was, providing support with this launch was let's get comfortable with the uncomfortable questions. And as soon as we do that, we can get to the baseline of what's going on. And it's worth it because this demographic information that we're collecting is truly the baseline and the foundation for the work that we do to improve outcomes and data. And it doesn't have to be racial demographics. If there are issues in age, if there are issues in zip code, if there are issues in any other, and I'm using the word demographic very widely, if there are issues in that data collection process, we are hindered from that point on of understanding how we can find a solution because we don't know who our population is. So, whatever it takes to have those important conversations, dig into the data, and when someone is making data analysis and assumptions about data analysis, my favorite question to ask is why? Why are you assuming that about the data? Where does that come from? Are you taking it from literature of mass population of the US? How can we cater that to who we know our neighbors are in this community? The uniqueness of the surrounding counties and our communities. And that's why I took such a maybe customized approach to our data collection because what works in California or New York is not going to be the same thing that works in Shawnee County, Kansas. And we, as residents of these areas, are the best people to set ourselves up for success because we know our people. We know who we see when we walk through the doors of the grocery store. We know um, who is starting to migrate into our communities, and we need to use that knowledge as leverage to get better data.
Do you see the question in the chat? Okay. Emerson, there's a question from Heather Brom just saying, for my policy line in this work, is there a central up-to-date place online, like a central repository or library, where to find the different CHANAs and chips throughout the state to find out what's unique or similar from a state level informed by local needs? She'd be really curious to see those who have a better understanding of local needs across the state, and wondering if such a list exists.
That is a great question. I believe there is one. It's not coming to mind now, but what I do know for a matter of fact, because it's an IRS requirement, is every nonprofit hospital who conducts a CHNA has to have it available on their website. So if nothing else, if you're looking for a specific community and you know that there is a nonprofit hospital that is there, go to that nonprofit hospital's website and add in CHNA or community health needs assessment, and it should pop up. And if it doesn't, they'll be in trouble from the IRS. So it should be from county to county available. And then I know our local health department also has a lot of our CHNA documents. I feel like there should be, or there is a website that houses all of them. I just can't think of what that place was, but if nothing else, each nonprofit hospital or the FQHCs, the health departments, the ones that are required to do this work, have to have it on their websites. I agree, essential place. And I'll have to look, and if I figure it out or remember where that is, I will email you that place, and maybe email it out to Tara or here, just to make sure that we all have access to it, because the work is so important.
Any other questions for Emerson? I also, one last thing about this topic, and then we'll close out for the day. The reverse conversation of not offending someone by the ask is offending them by the wrong choice. And I handed a patient a paper copy of her radiology order because she likes the paper copy. She might be my age or older. And long story short, it had said the wrong race on it, and she was pretty offended. And it was a mistake made by not asking. An assumption was made. So I think that we're also, the bilateral conversation of topics, and let's say the hard thing. Emerson, great conversation that really means more than just the data, doesn't it? I agree, Jamie Kim. Awesome job, Emerson. We are so thankful again. I knew you were going to nail it. Of course you did. Made us think hard. It's a whole purpose of learning forums. Next slide. I think we'll close out for the morning. And Emerson's contact information, you guys, will be on the slides that we'll send out. Tiffany's also always wonderful about sharing that out. It'll be on the website as well. And Emerson's really, really good about responding. So if there's some follow-up questions or help at your local level, I know she'd be willing to jump in. Related to important topics, and Carrie and I were talking this morning about a conversation regarding measles outbreak. We were asked to bring back some very popular speakers from our champion only in-person workday. These two folks that you see pictured are experts in the state and, quite frankly, region and national level regarding pediatric immunizations. And wow, isn't this a hot topic? They do a great job of unwrapping the difficult conversation. And quite frankly, the data is getting really nerve-wracking in terms of what we're seeing because of low vaccination rates. Conversation, let's have it. So our virtual fall conference is October 27th. Please mark that date down and share widely. It's for everyone in the state to attend. Again, you'll receive this information, including how to register, which is simply a link. And we'll be excited to see you all at that virtual conference. September Learning Forum coming right up. Again, if you have any questions for Carrie and I at the hospital or local level, we're excited to talk to you. Thrilled to close out this bundle and to get moving on the next one. I'll give you a few minutes back to your day. Thanks, everybody, and have a great one.